Hello everyone. Today's topic we'll be discussing thyroid tumors. All right. So, what are tumors? Tumors are an abnormal mass of tissue, all right, that are formed when cells do not die. All right. There are two types of tumors. There's your benign, not cancer, and then there's your malignant, all right, which are cancer. So the benign tumors are localized to one place, but the malignant ones are not. They tend to spread. All right, they invade the surrounding areas. All right. Now let's come to your thyroid tumors. All right. Let's start with the classification of your thyroid tumors. So we'll broadly classify them into benign and malignant. Right. Under benign, we have your follicular adenoma. Right. Coming to malignant, we are going to divide them into two categories. There's primary and secondary. Under primary, we have your medullary carcinoma, papillary carcinoma, and your follicular carcinoma. All right. Now, this follicular carcinoma is this follicular adenoma which is transformed into a malignant condition. All right. And then there's your anaplastic carcinoma. All right. So now coming to the secondary, these could be either from your metastasis, from your breast, colon, or your kidneys. All right. The second being local infiltration from larynx. All right. And third being lymphoma. All right. So now we'll be starting with the benign condition, follicular adenoma. All right. Let's start with its introduction. What is your follicular adenoma? It is a benign tumor, as we've seen. It is a benign tumor which arises from the glandular epithelium of the thyroid gland. All right. Coming to its etiology, we have sporadic causes and dietary causes. In the sporadic, it is your radiation, and under dietary, it is excessive iodine. All right. Let's come to its pathogenesis now. All right. So there are certain GS alpha receptors. All right. So these receptors undergo a certain somatic mutation. All right. So a somatic mutation of the GS alpha receptors leads to excessive or chronic stimulation of CAMP. All right. Now this causes a certain growth advantage to the cells. So the cells, they start acquiring growth advantage. All right. Which leads to clonal proliferation of the epithelial cells. All right. And this leads to autonomously functioning monoclonal thyroid adenoma. All right, now that was the pathogenesis. Coming to the investigations, lab investigations, RAIU, which is the radioactive iodine uptake test. We find hot nodules. All right, so now let's come to the morphological features of your follicular adenoma. All right, let's start with the gross. We have certain lesions. All right, now these lesions are solitary. All right, they are spherical, encapsulated. All right, the cut section shows gray white to red brown tumor tissue. All right, and we also see areas of your hemorrhage and cystic change. All right, so now that we're done with gross, let's come to its microscopic. All right, so your follicular adenoma has 4 patterns. All right, the first one being Hürthle cell adenoma. All right, in this, the cells which line the tumor follicles have a granular eosinophilic cytoplasm. All right, the cells lining the tumor follicles, all right, they have a granular eosinophilic cytoplasm. All right, the second pattern is your simple, also known as macro follicles. So in this one, the matured thyroid follicles are lined by your columnar epithelium. All right, coming to the third one, fetal, also known as micro follicles. These are smaller in size. And the last one being your embryonal, also known as trabecular. All right, now this gets the name trabecular due to the cells being in form of trabecules. All right, not follicles. All right, so these were the 4 patterns that we would see in your follicular adenoma. The first one being your Hürthle cell adenoma, second being simple or macro follicles, third being fetal or micro follicles, and fourth being embryonal or trabecular. Right, we see compressed thyroid tissue. We can see that the thyroid tissue is being compressed. We can see the capsule. All right, we can see stroma here, myxoid stroma, and we see fetal follicles. All right, we also see your Hürthle cells here. All right, so that was your follicular adenoma. Okay, so now we'll be starting with papillary carcinoma of thyroid. Now this is the most common form of your thyroid carcinoma. All right, coming to its etiopathogenesis, let's start with the sporadic cause first. Which is your radiation. All right, any form of radiational injury. if you would recall the Chernobyl incident, after this Chernobyl incident, many people around the area suffered with your papillary carcinoma of thyroid. The second being your genetic causes. All right. Now, this is the most common cause for your papillary carcinoma of thyroid. There are two genetic causes. One is your BRAF mutation. All right. And the other being translocation involving the RET gene. All right. So this leads to increase activation, which leads to increase in your proliferation of cells. All right. Coming to the third cause, that is excess of iodine and TSH. All right. So what happens is, in regions where endemic goiter and there is increase in your iodine consumption, leads to increase in an incidence for papillary carcinoma. All right. Now that we're done with the etiopathogenesis, let's come to the subtypes. So, papillary carcinoma of thyroid has three subtypes. All right. One being your tall cell variant, two being your diffused sclerosing variant, and third being your follicular variant. All right. Now let's come to its morphological features. Let's start with its gross. All right. So here we see the papillary tumor. All right. We see that it is scar-like. All right. We also see that it is, the cut surface shows areas of gray, white. All right. And we can also see that the thyroid tissue here has been compressed. All right. So these were the gross features. All right. Now coming to the microscopic features. All right. You're wondering what this cartoon is doing here. We'll get to it soon. All right. Coming to the histological features, there are 4 hallmarks, right, for your papillary carcinoma of thyroid. One is your papillary pattern. All right. 2, we have a certain type of tumor cells. All right. Then we have your invasion, the 3rd hallmark, and the 4th hallmark are your samoma bodies. All right. So we see here that we see the papillary pattern here. All right. There are papillas here. So that was one of the hallmark. The second, pay attention on the tumor cells. All right. We see these tumor cells are optically clear. All right. Optically clear. And these tumor cells, when observed under the microscope, they resemble the eyes of this cartoon character, this comic character. She was named Orphan Annie. So that's why these tumors are known as Orphan Annie eye nuclei. All right. And then we also see a fibrovascular stalk here. All right. A fibrovascular stalk. All right. So, all right. Now these tumor cells are also have a ground glass appearance, so they're also called as ground glass nuclei or orphan Annie nuclei. All right. Now let's come to the clinical manifestations. Right, the clinical manifestations of your papillary carcinoma of thyroid. The patients are usually asymptomatic. All right, but there is regional lymph node involvement. All right. Now let's come to its prognosis. Overall, it has a good prognosis. Alright, so now we'll be coming to the last topic of thyroid tumors, that is the medullary carcinoma of thyroid. Now, the medullary carcinoma originates from the parafollicular cells. Alright, the parafollicular cells or the C cells of your thyroid gland. Alright, now let's come to its etiopathogenesis. So, let's start with this. Any familial occurrence, sporadic and syndromic. Alright, so usually 80% of the cases are sporadic, the remaining 20 are syndromic. Alright, so the syndromic usually involve your MEN, that is your multiple endocrine neoplasia 2A, 2B. Now these collectively lead to a single gene mutation, alright, leading to your RET proto-onco gene. And we know that this leads to increase in the activation of cells, which leads to their proliferation. Alright, so with that we're done with the etiopathogenesis. So now we'll come to the features of your medullary carcinoma. Alright, so the tumor cells secrete certain peptides. Alright, examples: calcitonin, prostaglandins, histamine, VIP, which is your vasointestinal peptide, and also your ACTH. Alright, now we have amyloid stroma. Alright, this is because of your amyloid deposits, and this amyloid stroma stains positively with your amyloid stain, example Congo red, so stains positive for Congo red. Alright, now these amyloid deposits, they represent your calcitonin. Alright, now let's come to the symptoms. So what are the symptoms? Alright, we see that there is increase in your calcitonin, alright, but there is no hypocalcemia. Alright, and medullary carcinoma also leads to paraneoplastic syndrome. Alright, this is because of increase in your vasointestinal peptide, which leads to your diarrhea, and increase in your ACTH, which leads to your Cushing's. Alright, so those were the symptoms. Now let's come to the morphological features. Alright, let's start with the gross features. Alright, coming to the gross features, we see that the tumor is soft, alright, and there are areas of hemorrhage and necrosis. So that was all about gross. Now let's come to the microscopic features, the histological features. All right. We can see calcification. All right. Areas of calcification. We can see the amyloid stroma here. All right. We also see an organoid pattern, and we can also see your tumor cells. All right. This calcification denotes stored calcitonin. All right. So by that we have concluded today's class. We are now done with the thyroid tumors. A quick recap of whatever we did today. We read about thyroid tumors. All right. We read what tumors were. They were an abnormal mass of tissue. All right. These abnormal masses formed due to cells not dying. There were two types: benign and your malignant. All right. Benign, not cancerous; malignant, cancerous. Thyroid tumors were of two types: benign and malignant. Benign being your follicular adenoma, malignant being your medullary carcinoma, papillary carcinoma, follicular carcinoma, and anaplastic carcinoma. Out of this, your papillary carcinoma being the most common one. All right. Then we went to the benign condition, follicular adenoma. All right. And then we went to the malignant condition, papillary carcinoma of thyroid. All right. And then the last topic we did was the medullary carcinoma of thyroid. Right. So by that, we'll conclude today's video. Thank you for watching.